Hello, I am Rob Hilvers, the physician and medical director at Emergency Responders Health Center. I'm happy to be here today to introduce a policy that many of us have been working on for several years, the Infectious Disease Post-Exposure Policy. It's live, and my goal today is to help introduce this to fire, police, and paramedic agencies, one, to understand the policy, and two, how to utilize it. The simple goal is to protect all our first responders following a potential exposure, which could include needle sticks, blood splashes, or any exposure involving bodily fluids that have the ability to transmit an infectious disease. Today, my hope is to provide some simple background information and to briefly review 3 documents that make up this policy. As well, I hope to cover some clinical information about each specific disease, specifically HIV, hepatitis B, and hepatitis C. First, I'd like to give a big thanks to the coordinated effort of the Access Committee, TVEMSS, Emergency Responders Health Center, and our local hospitals. I especially want to thank Dina Hardaway from Ada County Paramedics, Janet Brooks from West Valley Medical Center, and Samantha Birch from St. Alphonsus Regional Medical Center. Each of them have been vital into getting this policy adopted into their hospital systems. So let's look at a typical scenario. A needle stick occurs. The goal is to get it documented, to get the source patient's blood quickly drawn, to get it transported to a local hospital lab, appropriate tests run, and results called back out into the field, ideally within 1 to 2 hours. If there's a critical lab result, for example, if the source patient is HIV positive, then we have an appropriate window for the first responder to receive post-exposure prophylaxis, which is preventative treatment to help prevent the transmission of HIV. I recognize this ideal 1 to 2 hour window is extremely challenging, yet the message really should be the sooner the better. We have up until 72 hours to initiate treatment, but again, the sooner the better. So there are 3 documents within this policy. I want to briefly just touch on each now, and then I'll review them in more depth in just a moment. The first policy is the Infectious Disease Post-Exposure Policy. I'm going to refer to it as policy. It's a 2-page policy that really reviews the what's, the why, the how, the when, and the who. Document 2 is the Infectious Disease Post-Exposure Form. I'll refer to it as exposure form. This is really the meat of our policy. It's fairly simple, straightforward to fill out, but yet it provides critical information about the source patient, the exposed responder, and the contact information for the designated field officer, so that the lab staff knows who to call to give the results to. Finally, it's really important that the exposure form follow the source patient and then ultimately the source patient's labs or blood samples all the way to the hospital laboratory. Otherwise, the hospital laboratory may not know who to call results to. Document 3 is the Instructions and Clinical Reference Guide, I'll refer to as guide. It's a 3-page guide that provides instructions for how to fill out the exposure form. It outlines our local hospital systems participating in the post-exposure protocol and reviews some specific clinical information about each infectious disease. Again, HIV, hepatitis B, and hepatitis C. It really helps provide some information to the responders about the commonly asked questions. Each of these 3 documents lives on our website, so I'm going to take you to the website now and we'll review those. Now transitioning to our website at ERHC.org. The most up-to-date version of each document will live on our website. We're on our homepage right now. If you look at the right upper corner, you'll see Occupational Health tab. If you click on this, it'll open some documents. The top one is Infectious Disease Post-Exposure. Here are those 3 documents we were talking about. Each of these documents is easy to print, and the exposure report form should be carried by both EMS and fire departments. So let's start with the policy. So the Infectious Disease Post-Exposure Policy. We've talked about a lot of this already. I'm just going to review a couple highlights. So background, this policy is well aligned with both the CDC and standard practice guidelines for post-exposure management. The purpose is twofold. One is simply just to coordinate an expedited pathway for source patient lab testing and to be able to offer preventive treatment for an exposed first responder within an ideal optimal time frame. Scope, this policy is for all our local fire, local law enforcement, and paramedics EMS personnel within Treasure Valley, so includes all of Ada County and Canyon County. Revisions, we hope to keep improving and changing this form, so please send any changes or comments to me directly. And then page 2 of the policy, up on top, there's some common definitions that we use throughout the policy. You can look at those there. And then finally, response protocol. So just a couple highlights. It'll go over some information for both the exposed responder as well as for the source patient. Under exposed responder, just some reminders about skincare, right? How to decontaminate. What do we know? So lots of fluid, right? High volume lavage. Warm soapy water is great. And then alcohol is considered virucidal for all of these pathogens. So, if you have access to alcohol soap, that's great. Highlight in red, do not transport the exposed responder to the emergency room. Again, unless something else is going on, the responder really does not need to be in the emergency room. They can stay on duty if they are comfortable with it. And then under the source patient, to highlight here is that it'll walk you through how to alert our participating hospitals that one, there's been exposure, and that to let their lab team know to quickly get blood tested and back out to the field. And we'll review that in just a minute. So this is our exposure report form. This is the one-page form that is really the focal central point of the entire policy. It's a really important form that will allow, again, allow to quickly get the source patient's lab tested and to get the results called back into the field. And also gives the information about who's on call so the lab knows who to contact. Otherwise, if we don't send this form in with the source patient and ultimately the source patient's blood, the lab may not know, one, an exposure occurred, and certainly won't know who to contact. There's 5 sections. There's the source patient, there's the exposed responder, hospital lab orders, section 4, billing information, and finally the results communication section. And then under each section you'll see either a red or a red and an orange or just an orange highlight here. The red is to be filled out by the field supervisor, and the orange will be filled out by the hospital systems. So looking through each section, at the very top there's some general information. There's the ESO incident number, so if you have that available, please fill that out. The date and time of the exposure, and again the agency involved. Under section 1, the source patient, we really like to know the legal full name of the source patient and date of birth. As providers, it'll allow us to be able to look them up in the hospital systems to track their lab results. Status, is the patient alive, or unfortunately did they pass away? Disposition, where did they go? Did they get transported to the hospital, and which hospital? Were they able to stay at home? Were they transported to corrections or jail? Again, or did they unfortunately pass away and they're now at the morgue? So blood specimens, currently we're only able to draw the source patient in the emergency room or in the hospital system. In the future, we hope to be able to do source patient lab draws in the field. We're working on a policy and kind of the legal consent, so medics are going to be able to do that. I think this would be tremendous in situations where the patient stays at home, potentially goes to correction, or certainly the morgue. We'd like to know about risk factors. Do you know there's a history of IV drug use, or the track marks, etc. So section 2, exposed responder. Again, full name. We'd like to know their preferred contact number so we can reach them, and then agency they're with. And then the rest of this section really talks about the extent and the type of exposure. This becomes really helpful for occupational health or us to make a determination of the extent of the exposure, and does somebody need post-exposure prophylaxis. So walk through this briefly. Needle sticks, we'd like to know what size needle, and was it hollow bore like an IV needle, or was it a solid needle like a suture needle? We want to know the depth of penetration if available. Is it superficial? Was it subcutaneous? Was it intramuscular? Or was it an intravenous stick? Was there source blood visible on the needle? So before you got stuck, did you see the patient's blood on the needle tip? And then post-puncture bleeding. After you got stuck, did you start bleeding? And then there's some information about fluid type for other exposures, and then there's some room here for details of the exposure. So please fill out this out. Again, it helps us. And then there's a reminder about follow-up. I think it's important that the exposed responders follow up with either Emergency Responders Health Center or Occupational Health within 48 hours of exposure, 48 to 72 hours of exposure. There's several important reasons. One is to allow the case to be formally documented with work comp. Number 2 is that a medical provider's had a chance to review the full source patient lab results. 3, is to perform or arrange testing for the exposed responder if it's necessary. 4 is to discuss possible prophylactic medication treatment for the responder. And finally, to answer questions. I've had some of these high-risk exposures create tremendous anxiety for the responders, so it's an opportunity for us to discuss real risks, which we do with family members, and what kind of treatment or options do we have. All right, hospital. So we want to know which hospital they went to, and then what lab tests are we asking hospital to do. 99% of the time you can just check this routine panel. What we're asking for is rapid HIV, hepatitis B antigen, and hepatitis C antibody. I included this TB, in the event that there's a high-risk source patient TB exposure, that in the hospital systems we could draw and alert them to do a TB serum test on the source patient. Orange section here, this is for the hospitals. Some of our hospital systems require the providers to eventually sign this document within 48 to 72 hours. So they can put the provider, they can send it to us, we can sign it and fax it back. Section 4, billing section. This is simple, just which work comp agency are they with? Most of our agencies use Idaho State Insurance Fund. Ada County uses Intermountain Claims, and then Boise Fire and Police use Corvell. And then finally, results communication. So this section's critical and really has 3 goals. 1, it provides contact information so that the lab staff knows who to call to the field to communicate the lab results with. Number 2, goal is to protect HIPAA privacy for both the source patient and the exposed responder. And then finally, to fax the completed exposure form and the lab results to Emergency Responders Health Center. We want to make sure that we can act as a default resource provider for all of these cases. Individuals are welcome to follow up with any of the hospital systems, occupational health centers, but we want to make sure these cases are caught. So let's talk about sections 1 and 2. Again, they want to know who to call it to. So this, we think in most cases, it's going to be the EMS supervisor, either Ada County or Canyon County. So you can just check either of these boxes. The default numbers are there. If it's somebody else, please fill out the name and phone number, contact number for that individual, the field safety officer. Once the lab's ready to call it, if they can't reach this person, they will call Emergency Responders Health Center. They'll call our main number. For after hours, they'll follow prompts. They will get a 24/7 provider on call, and then we can discuss results. The hospital then will fill out sections 3 through 7. They're going to first document who they spoke to, who was the safety officer. They will confirm they have the right case, usually by matching the date and time of the exposure, which is written above, or they could use the incident number. And then they're going to give you either a positive or negative HIV result. That is the only critical immediate piece of information. And then finally, they're going to take this form, they're going to complete it, they're going to attach a copy of the completed labs, and they're going to fax it to Emergency Responders Health Center. A couple last comments. One is that there really should be 2 copies of this form. The first copy has to stay with the source patient and then the source patient's lab work all the way to the lab. That's critical. Number 2, there really should be a copy that stays in the field. So I think initially we're going to ask our field officers to fill out 2 copies of this, but know that we're working to get printed duplicates or triplicate forms in the future. And then finally, the most important sections, section 1, source patient, section 2, exposed responder, and finally section 3, results communication. And finally, our last form. So our last form is the instructions and clinical reference guide. So I'm going to briefly go over the first 2 pages, and I'm going to spend some time and go over the clinical reference information for each of these infectious diseases. So page 1's pretty simple. It just tells you how to fill out the form, so it provides a little bit more in-depth review. So we talked about that. On page 2, 2 things. One, it provides information at the bottom of all of our hospital systems and how to alert each hospital if an exposure has occurred. Again, it's really helpful to alert them that blood's coming in and we need to get results back. The hospitals that have adopted this policy formally, so St. Alphonsus Regional Medical Center, they've been terrific to work with. So fortunately, there's a single phone number to call for any of their locations. So you call the St. Alphonsus Central MAC or Medical Access Center, and they can coordinate that. And then West Valley Medical Center. They have requested us to first call this primary number. This will ring out to their house supervisor who carries a phone 24/7. If they're not available, then we can call the second number directly, which will ring out to the emergency room. And then this middle section, this is for the future. This is hopefully once we're able to start doing field lab draws, this really provides instructions for how to do that. And I'll skip over that now. Finally, the last page, and I want to spend a little bit of time with this, is about just clinical information for each of these infectious diseases. And I'm going to start with HIV. This certainly causes most of the alarm. So what are the real risks of HIV transmission? So there's some good, fortunately, some good hospital studies looking at healthcare personnel involved with infectious disease exposures involving patients that had known HIV positive status. So what do we know? If you get a needle stick and the patient's HIV positive, the risks are 3 in 1,000, so about 0.3% of contracting HIV. If it's exposure on mucous membranes, then the risk is about 1 in 1,100 or less than 0.1%. If you get an exposure on intact skin, there's been no documented cases of transmission. So there's been 2,700 incidents of bloody fluid on intact skin, but there's not a single case of transmission, so that's great news. So again, if there's a blood splash on intact skin, we do not consider that an exposure risk. However, if the skin has a focal abrasion, if there's inflammation or it's chapped, then we consider that a real exposure. Bites, again, there's been no documented cases of a bite in a hospital system transmitting HIV. However, there have been a few rare cases on bites outside of the hospital system. Okay, so following a needle stick, how do we risk, well, let's talk about fluids first. So what fluids do we know that transmit HIV? Well, certainly, obviously, blood, also semen, vaginal secretions, and any potential fluid that has visible blood on it. So what fluids potentially transmit HIV? So cerebrospinal fluid, synovial fluid, which lines our joints, pleural fluid, peritoneal fluid, pericardial fluid, and amniotic fluid. So any of those deep bodily fluids that either surround organs or joints. So fluids not considered infectious unless they're associated with visible blood. So number one, saliva, nasal respiratory secretions, gastric fluid, vomitus, urine, sweat, and tears. So again, none of those fluids are thought to be transmissible without visible blood. And again, intact skin, again, is also thought not to be transmissible. So following a needle stick, what do we know about risks of contracting it? And again, there's some good studies about this. So risk factors, number one is a hollow bore needle. So again, if it's an IV needle, something with a center tube in it, there's a much bigger risk of transmitting excessive volume as opposed to like a suture needle, which is not hollow. Depth of penetration, was there visible blood on the needle from the source patient before you got stuck? Was the needle previously in a vein or artery of the source patient before you got stuck? And what's the terminal illness of the patient? A lot of these diseases, as people become more immunocompromised, the viral loads go up and the risks increase. So what about indications for post-exposure prophylaxis? So indications certainly are if the source patient's HIV positive, or if there's a high-risk unknown, moderate or unknown high-risk source. So an example would be if you're a law enforcement officer and you're at a rave party and you accidentally get stuck with a needle that nobody claims, we consider that a high-risk exposure. Up until more recently, we really, most infectious disease experts did not recommend post-exposure prophylaxis for low-risk cases. That's starting to change a little bit as our medications are getting better and there's less side effects. Again, the barometer is changing slowly on that. What about efficacy of post-exposure prophylaxis? Well, the initial studies were performed using zidovudine or retrovir. So it reduced transmission risk by 80%. So that's tremendous. Currently, we're using actually better multi-drug regimens that are thought to be even more effective. The 3-drug regimen that I most commonly used is a combination of Truvada, which is a dual agent, probably most people have heard of, and then either dolutegravir for patients that are not pregnant or raltegravir if patients are pregnant. The ideal window, again, is a tight window. The ideal window is in 1 to 2 hours following exposure, but we really have up till 72 hours to start treatment. Again, the message should be the sooner the better. All right, let's transition to hepatitis B. So interestingly, hepatitis B is almost 100-fold more transmissible than HIV following a needle stick. Immunizations, So all of our first responders should have received a 3-dose hepatitis B series at some point in their life, either as a child or during the military, or certainly before you started as a responder. If you are HIV titer positive, I'm sorry, hepatitis B titer positive, you are considered protected, and really lifetime unless you develop an immunocompromised condition. However, if you have not received all 3 shots, if your titer is negative or you're considered a non-responder, then you're not considered protected. We do fortunately have post-exposure prophylaxis. There's something called hepatitis B immune globulin, so there's a longer treatment window, and it's quite effective. Hepatitis C, again, about 6-fold increased risk of transmissibility than HIV following a needle stick. Unfortunately, we don't have any post-exposure prophylaxis. However, if somebody eventually converts to hepatitis C positive, we do have good oral antiviral treatment. So what we usually do is if it's a high-risk case, unknown source patient that we can't get blood on, we'll continue to do lab testing on the exposed responder, usually at least through 3 months, if not 6 months. Again, if they do convert, which usually will happen in the first 3 to 6 weeks, we can start oral antiviral therapy. All right, so that wraps up review of each of the 3 policies. After a typical presentation, I've been told that most of us remember 3 things. So I have 3 clinical take-home pearls for each of you. First, the first responder involved in the exposure does not need to be seen in the emergency room, unless there's a separate issue. If you've been involved with trauma, if you need a laceration repair, your blood work can be completed at an occupational follow-up within the next 1 to 3 days. And if the source patient happens to be entirely negative, if the HIV, the hepatitis B, and the hepatitis C is negative, we can often stop additional work up there. Second, the first critical priority is determining the source patient's HIV status. And finally, if post-exposure prophylaxis is necessary, the optimal window to start prophylaxis is in 1 to 2 hours, and certainly no later than 72 hours. Again, I recognize that 2-hour window is extremely challenging, but the message, again, the sooner the better. In summary, the infectious disease post-exposure policy, it's live. It includes all Treasure Valley Fire, Police, and EMS agencies. Our goal is to minimize the risk for first responders to contract any infectious disease following a potential exposure. Again, to review the 3 clinical pearls, number 1, no ER visit necessary. Number 2, first priority is determine the source patient HIV status. And number 3, if post-exposure prophylaxis is necessary, the goal is to start it as soon as possible. And that's it. Good luck to everybody out there, and I appreciate the service that each of you provides our communities. Thank you.
Well, not at the
Steve's going to grab my ass, I know it.
Not at the ankle line, man. Okay. Everybody freeze.
Freeze, jeez.
Okay. Awesome.